Good morning. This is Dr. Babak Larian, and I'm doing a live Q&A session for salivary gland tumors, salivary gland issues of all sorts. So we're going to start today by talking about a question that came in about a person whose husband is suffering from acinic cell carcinoma. So let's go ahead and take a look. So when you look at tumors in the saliva gland, what's interesting is that most of the tumors in the saliva gland happen in the parotid. The parotid is the largest of the saliva glands, right? So 80% of the tumors happen in the parotid, 15% happen in the submandibular, which is under the jaw, and 5% in the sublingual and minor salivary glands. Most of the tumor in the parotid gland are benign, 80% benign, 20% cancerous, 50% in the submandibular gland, and 70% of the tumors in the minor salivary glands are cancerous. So when there's a lump under your jaw, when there's a lump inside the mouth, it's very serious and it has to be looked at very carefully. All right? And these tumors can happen in any of the salivary glands, again, most common in the parotid, and most of the time they start by having no symptoms, right? And because people don't have symptoms, oftentimes the diagnosis gets delayed, and that's a huge problem. All right, moving on. So the World Health Organization has categorized tumors of the salivary gland into multiple categories. Benign, epithelial meaning from the lining of the saliva gland. There's 15 different kinds of benign. Pleomorphic being the most common, followed by Warthens, and then there's a whole list of others, right? There are 20 cancerous ones that are from the lining, mucoepidermoid being the most common, adenocystic, and then fifth in line is acinic cell carcinoma, the one we're going to be talking about in more detail. Adenocarcinoma, malignant squamous cell carcinomas are very aggressive tumors. Mucoepidermoid comes in many different flavors. It comes in at low grade, which is very, very low grade and very unaggressive. Right, it's still a cancer, but less aggressive, or it comes intermediate grade or high grade, which can be very aggressive, right? And then there's adenoid cystic, which is an odd type of cancer that likes nerves and likes traveling on nerves, and it's hard to get rid of unless you catch it early and do a thorough job of it. So has a lot to do with the luck of when you were able to diagnose this tumor and take it out, and how skilled your surgeon is, and so on and so forth, right? In any case, acinic cell is here. It is on the lower side of aggressiveness as compared to the other tumors that occur in the salivary glands as a whole. All right. And the most common tumor overall is pleomorphic adenoma. If you look at it overall, close to 70% of the tumors that happen in the saliva gland is of pleomorphic adenoma type. All right, so let me flip this around. All right, so acinic cell carcinoma is, actually, let me show you one other thing, which is really important. Let me flip you around. So the reason you get so many different types of tumors is because the saliva glands have many different types of cells, so each of them can have a different tumor type occurring in them, right? And so that's why you have such a variety of tumors, and they're between, let's say, the green section here and the whitish or the pinkish section there are stem cells that make this and that, and those stem cells allow the cells to turn into anything. And if you get cancers from those cells, then the cancer can be anything that is around here. That's why you get such a variety. And this shows that. This shows, again, these stem cells. The pink ones are stem cells and then become other things. In any case, let me zoom in here so you can see it. All right. So, in terms of acinic cell carcinoma is an interesting kind of cancer. It is very low grade majority of times. It is a very tenacious kind of a thing, you know, and it cannot be taken lightly. Most are show up as a small lump in the gland that can move. They are usually relatively firm, but not like a knuckle necessarily. The most important thing to do is to do a needle biopsy and find out what it is. And once you have that and you know it's acinic cell, then you have to decide the extent of treatment. Acinic cells are interesting again because the majority are very low grade. The majority that I see in my practice come in at an early stage, so they're on the smaller side. Patients tend to not let them get massive, although that does happen, and I have taken out big, large tumors. They are, generally speaking, they are low aggressiveness. And, you know, on the scale of aggressiveness, they are on the lower side of aggressiveness. By that I mean their tendency to spread to the lymph nodes is low, the tendency to spread to other parts of the body is low. But having said that, they do get into the lymph nodes and they can spread to other parts of the body. So you cannot take it lightly and you have to address it. It is an odd tumor because you have to follow the patient who's had acinic cell carcinoma and has been treated for it for a lifetime, because they tend to have recurrences that may occur even 15 years later. I just saw a patient who presented with a recurrence in the clavicle, in the bone, that happened 15 years after they took out the parotid gland with an acinic cell. I don't have the reports of the product to know how thorough a job that was done in removing it, to see if there was some margins and issues and so on. But in any case, 15 years later, it did show up in the clavicle. So you have to really follow these patients. So the most important thing for acinic cell is a thorough, complete surgical treatment the first time around, right? So that we can remove it. Now, acinic cells tend to be a little odd, and there's a little bit of controversy around them because there is a tendency for them to happen on both sides. There's a few percentage points, like 3% of people who have them can have them in both parotids at the same time or at different times, which tells you that there's probably a genetic predisposition towards having this type of tumor if it happens two cancers in the salivary gland on two opposite sides. So there is an issue with multicentricity, we call it, multiple centers of tumor being present. And so that is a concern. And for people who have the diagnosis of acinic cell carcinoma, we actually have to do MRIs and thoroughly look at all the other saliva glands just to make sure there's no other lesion anywhere else that may be another tumor or another cancer hiding in another saliva gland, right? So we have to be cautious. MRI, after you do a needle biopsy, an MRI is the most important thing because it'll show you if there are lesions in the saliva glands or in the in the lymph nodes around there. So if the tumor is here, let me see if I can show you something else. I'm gonna flip this around for you. So this is the saliva gland, and that's how a tumor grows in the parotid gland, right? And so if this is an acinic cell carcinoma, let me do it in black here. It could also spread through the lymphatics to the lymph nodes in the neck, right? And by doing an MRI, you can assess the lymph nodes and see if they look enlarged or abnormal. Ultrasound is also a very good way of looking at lymph nodes to see if they have any pathologic features that makes them look suspicious. But when treating cancers in the salivary glands, you really have to always figure out if the lymph nodes in the surrounding area need to be addressed, right? And majority of times, tumors in the parotid either send cells into lymph nodes inside the parotid gland, right? Which there are 3 to 4 lymph nodes inside the gland itself. So on the MRI, you can assess and see if there are lymph nodes that you see, in which case during the surgery, you want to make sure you remove them. And you can do that with ultrasound as well. Ultrasound is very good for most of the parotid gland except the deep portions of it, right? And then you can also assess the lymph nodes. Now, if the tumor does not have any involvement of the lymph nodes and you see normal lymph nodes, when you do the surgery, what you have to do is not only remove the tumor, but also a margin of safety around it, right? Because these tumors may have tiny little legs that are microscopic and not visible, and you want to make sure that you've gotten everything around that, right? So you want to make sure you avoid these tiny legs that may be microscopically present so you get a margin. Usually the margins are affected by the facial nerve. So if you were to look, the facial nerve, let me start here. So the facial nerve comes in out of the brain and does 2 turns, a second turn inside the ear and comes out and goes into the parotid gland, right? It exits through a hole in the skull and comes out and enters the parotid gland and then divides into 2 branches. The lower branch, which goes to the lower lip and smile muscles, the upper branch, which goes to the upper lip, smile muscles, eye, and eyebrow. And so if you have a tumor, let's draw the tumor, that's like this here, then when you're trying to remove it, you can remove in all direction except when you get to the nerve. When you get to the nerve, if the nerve is working, you try to separate the tumor from the nerve, right? If there's a distance, well, obviously that's fantastic. If there is no distance, then you try to separate the tumor from the nerve. You try to not sacrifice the facial nerve for it. In which case, what you may have to do is, if under the microscope, when they look at it, they see that, no, actually there was a little bit of a distance, right? There is a blue separation, then you're fine. If, on the other hand, they see that, no, your tumor was immediately at the edge of what you removed, right? If the tumor is right at the edge of what was removed, then what you may have to add is radiation treatment afterwards. So indications for doing radiation for acinic cell carcinoma is advanced stage tumors, so larger tumors and tumors that have spread to lymph nodes. So if you have a couple of lymph nodes involved and tumor has gone from here to there, then there could be tumor cells in transit in other directions, in which case you need to do radiation to cover all these tumors in transit and all the ones that may be in lymph nodes that are microscopic and yet not bigger enough to be visible. Okay? Or if your margin is close up there, all right, those are indications for doing radiation treatment for acinic cell carcinoma. Now, acinic cell carcinoma, again, majority fall into the low-grade variety and low-grade version, but some of them, all right, some are high-grade. And when you look at under microscope, you can see some features that makes the cancer look higher grade and more likely to be problematic, in which case you may have to use other treatments such as radiation treatment, right? But I'd have to say, probably 95% of the acinic cell carcinomas that I take out, surgery alone is all that's needed. You know, usually I do very thorough, meticulous job. I take my time doing these particular surgery, and make sure that that it's a complete thorough job and it's clean. And I may even in the operating room look at the margins of what I removed, get samples of the edges of what I removed. Let me show you. So in the operating room, I may get a biopsy here. Let me do it in red. I may get a sample here, sample here, sample here, sample here, to make sure the edges are clear. And if the edges are clear, I'm good. And if the edges are not clear, I may remove a little bit more in that particular area, right? In any case. So the detail of the work, the meticulousness of the work really matters for cancer treatment, of course, as a whole, and in this particular area, and the experience with the nerve. You know, when nerves are working, okay, I'd say 99% of the time we are able to preserve them. You know, 1% of the time when we go in there, in cancer cases, we see that the tumor is really wrapped around the nerve and we can't separate it. Even though the nerve is working and we'll do our best to try to maintain it, we know that it's going to be hard to get rid of. The tumor cells around the nerve, and we may have to sacrifice it, but that's a rare thing. Usually when tumors are next to the nerve and haven't eaten through the nerve and the nerve is functioning, we're able to separate the tumor from the nerve and preserve the nerve. And we take our time in doing so. And if we suspect that the tumor has some involvement with the nerve, maybe the upper lip is a little weak as compared to the other side, and you know, we look at older pictures and that weakness wasn't present, then we know that tumor is eating through the nerve, and then we'll prepare ourselves during surgery to reconstruct that nerve and improve the function of the nerve. So again, preparation is really key, and the experience of your surgeon is really the key in how you address these tumors. All right, so Ginny Clark Caldwell, I hope that answers your questions about acinic cells. Acinic cell tumors are unfortunately more common in middle-aged men. So between the ages of 40 and 50 is the most common group. So that's the target. 40 to 50-year-old white men is the target audience. You know, each tumor is a predilection for different. Most tumors of the salivary glands actually have a preferential incidence in women. Unfortunately, poor women get all these glandular issues because their glandular tissue is more active than men. And so they get into trouble more so as well. But this particular tumor prefers men of the Middle Ages. So at least one glandular issue is not tilted to women of their Middle Ages. In any case, so it's Ginny, your husband is the target audience essentially for this tumor, and please make sure that you find a good surgeon and address it very effectively and quickly, and then make sure that they do a thorough job of diagnosing it and looking at the lymph nodes in the neck and so on before starting the surgery, so that they know exactly what they're doing. All right, best of luck, Jeannie. If you have more questions, don't hesitate to let me know. I'm happy to talk to you. Number 2, question is, will it hurt to be on a keto diet while one is recovering from surgery? Protein and vitamins are the most important thing in recovering from surgery, because your body uses those as building blocks to heal, to make structures and heal incisions and so on and so forth. I really firmly believe that you should not be on a diet as you're recovering from surgery, because we're not as smart as we would like to think, and we're not as thorough in providing nutrition for ourselves. I would say that in the recovery phase, make sure you have a lot of protein, a lot of fruits and vegetables, so that the vitamins essential for the healing enzymes are present and the building structures are available. So I wouldn't do a keto diet during the recovery period. All right. And next questions is about pleomorphic adenoma. Will the tumor recur again? This is by Arzu. Arzu, it depends on multiple factors. Let me see if I can explain. Here we go. So, pleomorphic adenomas are odd because they don't have a complete capsule. So the gray line here is the capsule. This is from a picture that I drew for a textbook chapter on pleomorphic adenoma. And so the covering of the pleomorphic adenoma is not necessarily always complete. There are gaps, like here. That's a gap in the covering, right? So the tumor cells can come out of the capsule here. And so they can come out and look like kind of a finger-like projection. They can bulge out and have a capsule over them, like this area. And infrequently they can have a separate piece. We call it a satellite piece, right? That are separate. This is very rare, right? And so if the surgery is done such that you're so close that as you're doing the surgery, and these are the legs, right? So we call them pseudopods. If the surgery is done so close that some of those legs are amputated and the whole tumor is removed, but those amputated legs over time can grow and become tumors. Sorry. So each of those amputated legs, and we'll look at it again, this may be helpful. You can see those little amputated legs, each of them turns into a tumor. So this person would have 1, 2, 3, 4 tumors years later. And so this has to do with the skill of your surgeon, and but it also has to do with how close the nerve is. So if the facial nerve was sitting right there, right? If this is the facial nerve, if this is the facial nerve, and it's sitting right next to the tumor, you may not have the luxury of being able to get away from the tumor well enough to avoid those legs in that area. Having said that, the incidence of recurrence is exceedingly low. I find that probably the most likely cause of recurrence, rather than these legs being cut, which can be the reason, is if the tumor, because it has an incomplete capsule, right? So if the areas of incomplete are much more for the particular tumor, right? So if you have a tumor, let's go here, right? So let's say, and I'll draw it here. If you have a tumor that has 2 areas of gaps, right? As opposed to a tumor that has multiple gaps, right? These tumors that have multiple gaps, when you're trying to move the tumor and manipulate it, can burst open more easily because they don't have a contiguous capsule covering it. Those particular tumors tend to rupture and can have spillage of some of the tumor cells as it ruptures and breaks open, right? And I feel that those ruptured tumors are the ones that are more likely to cause recurrence. So When I get a rupture, and again, the rupture has to do with the integrity of the capsule surrounding the tumor and how you handle the tumor. So the more experienced surgeons tend to handle it better, and the incidence of spillage is less. But spillage happens for all surgeons, unfortunately, because that's just the nature of the tumor itself. But if it does happen, right, you try to minimize the spillage and control it. If you see it, you immediately suction that area and get the cells out. And then you cauterize any area close to that is not nerve, so that if there are any cells that were free floating in that area, you cauterized and killed them, right? And then I also wash with like a liter of water to flush it out. So in doing these things, the incidence of recurrence can be very much minimized. So Arzu, the recurrence has to do with the integrity of the capsule of your particular pleomorphic adenoma, the skill of your surgeon, and the experience of your surgeon on what to do when spillage occurs, okay? And by doing that, you can really minimize recurrence. And despite having close margins a lot, I'd say probably more than 85% of the tumors that I remove are sitting on a branch of the facial nerve, so their margins are close. Despite that, and I'd say probably a single-digit percentage of patients have spillage when I'm doing the surgery because of the nature of the capsule. Because of all the measures that I take and I do, in all the years I've been doing this, I've had only one person have a recurrence, right? And that has to do with the fact that I'm looking for it, I'm watching for it, and I'm managing and taking care of it. So you need your surgeon to be doing the same thing, okay? In any case, I hope this is helpful. I hope you guys stay safe and take care of yourself. And if there's any other questions that I can help with, don't hesitate. Have a wonderful, blessed day, and stay healthy. Bye.